Introduce Dr. David Shute. He is the Medical Director of Quality Corp, as well as the Medical Director of the Greenfield Health Clinic.
Great. Thank you, Steve. So I'm going to try to move around while I talk, just because Harold is my hero, and I try to be like Harold whenever I can. Now, so I have the privilege of sharing with you some data from the Dartmouth Atlas report. And this report came out fairly recently, actually in September, and so we're giving you a quick high-level look at that. There's lots more data down below the surface, but wanted to just share that with you a little bit. Is everybody here familiar with Dartmouth Atlas and what that is? Pretty much, a couple knows. Very quickly, that is a data set, huge data set of Medicare data, fee-for-service data, that's been looked at for quite a long time now, and is famous for looking at regional variations in utilization. So big data set, and it continues to be a rich source to look at things. This is now a recent report looking specifically after what happens after hospitalization. And so we thought this would be a good thing to look at, both to give you a sense of where Oregon lies in comparison with the nation, and also where our different regions, how they compare with each other. And then lastly, I think this begins to give us a glimpse into maybe why there's some variation, and perhaps propose some questions about what may be going on and how we can look for opportunities. So very quickly, who is in this data set? This is 100% of fee-for-service Medicare beneficiaries, okay? And this is included in the 306 Dartmouth Atlas hospital referral regions. Those hospital referral regions are really geographic chunks of where patients go into a set of hospitals. And we'll show you what that looks like on a map. But think of it really as the catchment area of a community of hospitals. So those are hospital referral regions. And this data is generated from the claims from short-term acute and critical access hospitals in those three regions. So really the same population of hospitals primarily that Stacy was describing before. And in this particular report, we looked at 6 different patient populations. Those discharged with medical conditions, surgical conditions, hip fracture, CHF, acute myocardial infarction, and pneumonia. And so in addition to those hospital referral regions, this report also includes academic medical centers, 94 of them across the country. They're treated differently because they both have different implications geographically. If you think of OHSU and you ask the question, what's its territory? Kind of hard to say. So academic institutions have a different geographic territory, and frankly, they care for a different population of patients. And so what I want to do now is look at some statewide data, beginning with Medicare patients readmitted. So this is all patients. And we'll first look at how the United States did versus Oregon. And this first bubble is surgical readmissions. So the US rate was 12.7% for 30-day readmissions. We're at 9.7. And that's, I think, the best story in all of this, is we're considerably more efficient or considerably better in terms of readmission for surgical cases. This is all medical readmissions. And again, we're a little better, 16.1 versus 14.4, but not a lot different. Clearly, higher readmission rate for medical patients. And then lastly, we looked at CHF readmissions. Unfortunately, COPD was not included in this report. For CHF readmissions, the national numbers are 20.7, still higher. Unfortunately, this report does not have Oregon numbers, and we don't know why yet.
We're tracking it down.
We're trying to get to the bottom of that, but right now we don't have the CHF Oregon numbers. So this basically shows we're clearly better in terms of surgical admissions, probably better in terms of medical admissions. Now, the other interesting thing this report looks at is outpatient visits to a primary care physician within 14 days of discharge to home. To me, this measure makes sense. If you're trying to manage transitions well, be proactive in patients' care, at the very least after discharge, they should be seeing a physician. And in this case, we're looking at primary care physicians. And again, this is, we'll break this down and show you a little bit. So in terms of the data for the US, within 14 days of discharge, 21.8 and 20% of patients saw a primary care doc. How does that feel on face value? Seems a little surprising to me, at least in my clinical practice, although this is visits now, but certainly folks should be checked in, I think, pretty much everybody within 2 weeks of leaving a hospital. I'm sorry, this is just surgical. Thank you for clarifying that. So this is surgical, but still that feels low. The other interesting thing is we're fairly similar to the nation. Now we'll go on and look at medical patients. And here, interestingly, higher numbers, still less than half of medical discharges are seeing a primary care physician within 14 days of leaving. Our numbers are a little higher if you assume outpatient visits are good. And lastly, we'll look at CHF. We do not have the Oregon data, but we do have, well, we don't have the national data on that. Sorry. Now, the other thing this study looks at is emergency room visits. How many of our patients after discharge are landing in an emergency room? And again, if you look at the surgical data, which is the best, 15%, and again, there's really no significant or no major difference between our numbers and the national numbers. In terms of medical admits, about 20%, Oregon surprisingly being a little higher than the rest of the country. And then with CHF patients, 23% wind up being in an ER within 30 days of discharge. So it's a little bit of the national data. Okay, so here's medical patients in terms of having ambulatory visits within 14 days of discharge to home. So again, here's the US and Oregon, and here's the CHF data. Okay. So let me talk now briefly about hospital referral regions, and then we'll look into the state data split up by our hospital referral regions. So basically they're defined as documenting where Medicare patients are referred for major cardiovascular surgery, surgical procedures, and neurosurgery. So this is looking at referral patterns for particular subsets of care, which are interpreted to parallel other referral patterns as well. And we have 5 regions: Portland, Salem, Eugene, Medford, and Bend. And on face value, that kind of makes sense. Those are the major referral regions in state. Realize that every referral region will have multiple hospitals within it, and that both Portland and Medford referral regions extend outside of our state. So this is not just Oregon patients. And conversely, I'm sure some of Eastern Oregon's patients land in the Boise hospital referral regions. Okay, so here's a map really quickly. This is kind of hard to read, but just gives you an idea of what these referral regions look like. What is sort of striking, at least how CMS has drawn the map, is Portland extends across the border into southern Washington and actually all the way east along the I-84 corridor. So that's how actually Dartmouth Atlas and Medicare draw this map. So let's go ahead and take a look at how things look for us by referral region. So starting with Oregon Medicare readmissions all total, and on the bottom you can see Bend, Medford, Salem, Eugene, and Portland. Interesting that we're all kind of in the same range, with Salem being a little bit higher. The average in the USA is 16%, so most of our referral regions are below average, with Salem again being a little bit higher. And then for, 12%, okay. And OHSU, just as kind of a reference point, is there. So those top bubbles are medical, and the bottom are surgical, correct? So again, if you look at it, wait, is that right, Steve? Mm-hmm. The bottom numbers are surgical. So if you look at it again, surgical care clearly has much lower readmission rates. Now let's look again by referral regions on patients seeing primary care physician within 14 days of discharge to home. And again, if you look at the referral regions, most of the places in Portland cluster around the 50%, with both Salem and Portland being below. And again, on the bottom are the bubbles are kind of hard to see. Those are the surgical follow-up rates, again with primary care physicians. The average And the US is about 43% for medical and 21% for surgical. So again, looking at this, we tend to have better follow-up post-medical admission with primary care physicians than other parts of the country. Does that explain our somewhat better performance? Don't know. I think that's a really good question, and obviously one we need to spend some more effort getting to understand and know a little bit better. And OHSU as an academic medical center has got the numbers there, intentionally trying not to compare those to the non-academic medical centers. And lastly, let's look at ER visits. Again, those top numbers are for medical patients. The lower ones in the pale blue circles are for surgical patients, displayed by referral regions. I won't read them to you, but again, the nationwide data looks like that. So interestingly, we do seem to have more ER use within 30 days after discharge, at least in our medical patients, which to me raises questions. You know, why are these patients going to the ER? What opportunities does that prevent for us in terms of improving their post-discharge management? And lastly, Oregon Medicare patients having an ambulatory visit, not primary care, but an ambulatory visit within 14 days of discharge to home. And again, this is interesting. Bend, and again, these, look at the numbers in the bubbles. The position isn't to scale, but Bend is considerably higher than the rest of the state in terms of their ambulatory visits post-discharge, with that being the national norm. OHSU down here, lowest of all. So in conclusions, trying to kind of wrap up what this says, and this is actually a new point here. One of the things from this report is that the data between 2004, this data, and 2009, what we just looked at, there's overall little or no improvement. Some regions went up a little bit, some regions went down a little bit in terms of readmissions, but there's essentially no change. And I think that's significant. For all the interest in the work, we're not making progress very fast. Secondly, we are a little bit lower than national rates, 1.7 raw percent on the medical side, 3% on the surgical side. So I think we can certainly take some credit or take some comfort that we're better than average. I personally don't think we should take too much comfort for that because these numbers still feel quite high to me. 46% of medical patients in Oregon did visit a primary care clinician. That's good. That still feels kind of low to me as a primary care guy. That seems like part of the way our system should work. Although 63% had one or more ambulatory visits. So over 2/3 of people at least are getting seen. The comment I would make is that these readmission rates and the ambulatory visits are really only indirect measures on how well we're coordinating care. One of the challenges of this data set is we're limited to fee-for-service Medicare claims, so it's just a sliver of the population. And it also doesn't get at some of the deeper questions of how well we're managing transitions and how well we're supporting patients, which are some of the themes that I think have come up in our conversations this morning. The next point is I think variability exists between the Oregon hospital referral regions. And when I saw this, I was actually surprised to find Salem higher. I don't know, certainly we don't know what this means, we don't know why, but it certainly raises some great questions for us to think about as a community as we begin to look for where our best practices and where are some of our opportunities for improvement. And my last comment is I don't think we know how big our opportunity for improvement is. We've got numbers. I think we've got a sense in terms of what our numbers should be, but I don't think we begin to know how big our opportunities are and where they are, whether it's based on a geographic region, whether it's based on different settings of care, whether it's based on different organizations. So to me, the take-home message in this is we've got variability and a whole lot more to learn about where to focus our work. And that's where I think we're really thankful to have the support of the other members on this panel and RWJ to help us dive into this going forward.
Thank you, David.